Hi, it's Susanna with Science with Susanna. And boy, this one's a doozy today. We're going to go through blood pressure regulation. And I'll continue to add questions after each page of your notes to make sure that you're really learning the material and getting the opportunities to practice that you need. Let's get started. We'll start with a diagram that shows how blood pressure changes as it passes through the systemic circuit. On the left side of this diagram, numbers like 0, 20, 40, 60, 80, 100, and 120. These represent what we call blood pressure, and we measure it in millimeters of mercury. Then on the x-axis, you'll see the various blood vessels themselves, like the aorta. You can tell it has the highest pressure, right? Along with these elastic arteries and muscular arteries. Then notice that the blood pressure really starts to drop as you pass through the arterioles, the capillaries, the venules, the veins, and then look how low it is in the vena cava right before it goes back to the heart. And then here, this is where blood returns to the heart. Blood returns to the right atrium. And maybe I'll add deoxygenated blood. And then here is where oxygenated blood leaves the left ventricle. And we all know that the heart, you can feel your heartbeat, right? Looked up. So there's a high point where the blood vessels are getting pushed out. And then there is a lower point where the vessels are as relaxed as they're going to get between heartbeats. So we call that top value systolic pressure, and we call the bottom value diastolic. So let's take a green pen and go along the top. This is systolic. And I just am going to stop right there for a second. Notice that it actually does go up a little bit. Look at that right there. Don't worry about that, but if you are wondering why that happens, it's just because the aorta is so stretchy that it doesn't resist the movement of the blood through it as much. But it's a minor thing. Certainly not something beginning students need to worry too much about. Okay, now I'm going to continue down. Look at how the systolic pressure drops and actually now becomes the same as diastolic, right? So this top green line is what we call systolic. And we measure that in the brachial artery. And so we usually would say that normal value at rest is 120 millimeters of mercury. Now I'm going to use an orange to show you the diastolic. So you can go along the bottom like this. And then notice that it becomes the same as systolic by the time it's in the arterioles. So that's diastolic pressure. And it's usually about 80 millimeters of mercury. The difference between the systolic and the diastolic pressure is what we call pulse pressure. And it's the difference. And so it's usually going to be about 40. So you see 120 minus 80 is 40. And notice that the pulse pressure then disappears. There is no difference once you get to the arterioles. This black line right here, that's the mean arterial pressure. The mean meaning the average. And we call this MAF. This is the average blood pressure. Your heart spends a little bit more time in diastole than systole. And so because of that, the average is a little closer to the diastolic value of 80 than it is to the systolic value of 120. If it was a perfect 50-50 average, then mean arterial pressure would be about 100, right? Halfway between the two. But instead, it's usually about 93 millimeters of mercury. Now, this matters clinically. They usually keep track of this because if it falls too low, then it's an indicator that perhaps the tissues are not getting adequately perfused. So I consider this a quick reading that's used to assess tissue perfusion. And tissue perfusion is how well blood is flowing through an organ in order to be adequate for gas exchange and nutrient delivery and waste removal. Now, let's look at what I think is the most interesting part of this graph, and that's right here in these arterioles. These are the arterioles, and this is where blood pressure drops the most. And there's a lot of these vessels, and if they're all constricting at the same time, or many of them, they can have the biggest impact on systemic blood pressure. They can increase resistance so much by constricting. Time to test yourself on that blood pressure diagram. So it's just some basic questions. I've got 5 here. This feature is an important way for you to learn. What you should do is after you've taken notes, ask yourself these questions and make yourself write down the answers and then go and check and see how many you got right. And then do it again and again until you are able to very easily answer all of the questions without looking at your notes. That is how you learn. Blood pressure can be thought of as how hard the blood pushes against the blood vessel walls. Blood pressure is determined by cardiac output, which is how much blood is being pumped by the heart every minute, and total peripheral resistance, which is how much the blood vessels are resisting that blood that's being pushed out of the heart. It's determined by cardiac output, and that's the amount of blood pumped by the heart in 1 minute. And it's also determined by resistance. We call it total peripheral resistance. And this is how much the blood vessels are resisting that blood that's being pushed out of the heart. Or the other way to think of it is how easy is it for the blood that's being pumped from the heart to flow through the vessels. This is TPR, and cardiac output is CO. Cardiac output, in turn, is determined by heart rate, which makes perfect sense, right? If you're trying to know how much the blood can pump in 1 minute, then you need to know how many times it pumped in 1 minute, how many times it beat. But that's not all you need to know. You also have to know how much it pumped each time it beat, right? And that's called stroke volume. So stroke volume is how much blood gets pumped out of the heart in each beat. And it's usually about 70 milliliters, but it can change. And let's look at what might change it. So it can be changed if the heart pumps harder, and we call that contractility. And this is the force of contraction. How hard is that heart beating? So if contractility increases, stroke volume will increase and cardiac output will increase. Stroke volume is also determined by preload, which is basically how much volume the heart has in it right before it beats. Now, I have to put a little qualifier out there. In physiology terms, this is not how we would always define preload. We talk about it in this fancy language of the ability of the cardiac myocytes to stretch, etc. But the more I've thought about what it means clinically, this is really what it comes down to. And I know those of you that are watching this are probably wanting to go into healthcare fields. So please, nobody get too mad at me that I'm being a little free with the definition of preload. But ultimately, it's like the volume in the heart. And that is going to greatly be determined by what's called venous return. This is how much blood comes back to the heart, and that's going to obviously then be almost identical to preload, right? So these words can have some overlap in their meaning. So that's going to be the amount of blood that enters the heart each cardiac cycle. And just depending on who your teacher is, you might get asked about something called the Frank-Starling law of the heart. These were a couple of hardcore physiologists that were very mathematical, and what they determined, Frank-Starling law of the heart. It essentially says that the higher venous return is, then the higher stroke volume is. Okay, so going forward, when we talk about regulating blood pressure, keep your eyes peeled for examples when heart rate is affected, because if heart rate goes up, cardiac output will go up. If stroke volume goes up, cardiac output will go up. And if cardiac output goes up, blood pressure goes up, because the equation for blood pressure is blood pressure equals cardiac output times total peripheral resistance. Now, speaking of that peripheral resistance, the main thing that is going to affect total peripheral resistance, which is the resistance of the blood vessels to the blood that's coming into them, is vasoconstriction. So we'll put that right here, vasoconstriction. That's your key idea. However, there is a long-term factor that we can also consider, and that's weight gain. As we gain weight, we have more blood vessel length in our body, and that increases the resistance. So the heart will have to push harder to get the blood through all of those vessels. We'll put blood vessel length, and it's going to increase with weight gain because we need more blood vessels to go through all that fat. Which is why people tend to have their blood pressure go up as they gain weight. But I made that one a dashed line because when we're talking about moment to moment and medications that might be given, or the effects of dehydration, or what could happen if someone has damage to their heart and they're entering congestive heart failure, all of those things, I want instead for you to think about heart rate, stroke volume, and vasoconstriction. Now, you can see on this page that stroke volume is the one that might get a little bit more complicated as we think about, okay, how is the force of contraction affected here? That's contractility. How is the blood volume in the body affecting stroke volume? Do you have a lot of volume of water and blood at that moment, or do you not have very much? And that's going to have a huge impact on stroke volume as well. And then, of course, venous return, how much blood is able to come back to the heart with each beat. Test yourself. I have 8 questions here that you can use to test yourself over the previous page. Go through these questions, write or type your answers, and then go back and check to see if you got them right. Then do them again and again until you can successfully go through all of these questions and get all of them right on the first try. Let's put our principles into practice and consider different ways and different hormones that could regulate blood pressure by making it go up or down. On the left side of your screen is a blood vessel. And as we talked about on the previous page, vasoconstriction can affect blood pressure. Increased vasoconstriction will affect peripheral resistance by making it go up. And if peripheral resistance goes up, blood pressure will go up because when you look at the equation, cardiac output times total peripheral resistance, vasoconstriction is directly affecting total peripheral resistance. Although I'm not writing it on this page, you could obviously see the other direction too. Hormones that cause vasodilation will decrease peripheral resistance, and therefore they will decrease blood pressure. The first hormone we'll talk about is epinephrine. It used to be called adrenaline, and so it binds to adrenergic receptors, which kind of sounds like adrenaline. These adrenergic receptors can be found on blood vessels, and some blood vessels will have adrenergic receptors that constrict in response to epinephrine, like alpha-1 adrenergic receptors will do that. But then there are others, like beta-2 adrenergic receptors, that can cause vasodilation. It just depends on what part of the body it is and whether that part of the body needs to have more blood flow or less blood flow at any given time. Epinephrine is released from the adrenal medulla. That's the middle of the adrenal gland. It will release epinephrine when you are in fight or flight, or so you have sympathetic stimulation, will cause, I think I'll put a little line there even, from the brain. Sympathetic stimulation will cause the adrenal medulla to release epinephrine. Then epinephrine will bind to the adrenergic receptors on blood vessels, and depending on which blood vessels they are and which type of receptors the epinephrine binds to, then vasoconstriction will either increase or decrease. and that will affect blood pressure. Epinephrine and norepinephrine can also bind to the heart. And in this case, they bind to a very specific receptor on the heart called a beta 1 adrenergic receptor. And when epinephrine binds to beta 1 adrenergic receptors on the heart, there will be an increase in heart rate and contractility. And that will increase stroke volume, which then affects blood pressure by changing cardiac output. So if we look at the equation again, you can see once more cardiac output is impacted by this hormonal change. Epinephrine, just as a review then, is released from the adrenal medulla. So see, I'm putting up there. Comes out of the adrenal medulla when you are in fight or flight under sympathetic stimulation. It increases heart rate and how hard the force of contraction in order to increase stroke volume, which increases cardiac output, which increases blood pressure. Another hormone that can increase heart rate and contractility is your thyroid gland, which releases a hormone called thyroxine. This is your metabolic hormone. And when your metabolism is faster, you need more blood flow and more oxygen going to your tissues. So this thyroid gland, one of the effects of the hormone it releases, thyroxine, is to increase heart rate and contractility. The thyroxine also can affect the heart and increase both heart rate and contractility also over a longer period of time. This is why if someone has hyperthyroidism, they might have high blood pressure. It's why if they have hypothyroidism, they might have low blood pressure. So these things are linked and the symptoms then make sense. Let's look at a third important hormone that affects blood pressure, and that's called angiotensin 2. Angiotensin literally means blood vessel tensing. So it doesn't surprise you probably that it would raise blood pressure. One of its immediate effects is to cause potent vasoconstriction. So I'll put that as job number A. It's a powerful vasoconstrictor. But that's not all it does. It also has a direct effect on the kidney to cause the kidney to increase the amount of salt that it's reabsorbing. So that's letter B. Increase sodium reabsorption. And when the kidney reabsorbs more salt, water always follows salt. And so we're going to end up with an increased amount of blood volume that's staying in the body. And if you can increase blood volume, then you're going to increase venous return. That's the amount of blood that's returning to the heart with each beat. And if the amount of blood is increased, then you're going to have an increase in preload, which is going to increase stroke volume, which is going to increase cardiac output. So we can once again see in our equation that if cardiac output goes up, blood pressure goes up. If there are hormones that can make the kidney hold on to more salt and water, you will have more water in the blood vessels, will increase venous return, which will increase preload. That's the volume that fills the heart. And then that means you'll have a higher stroke volume. Another way angiotensin does this is by stimulating the adrenal cortex. So this is the outer part of the adrenal gland. We talked about the adrenal medulla. Now we're talking about the outer part, the cortex of it. So this is the adrenal cortex. Angiotensin 2 will stimulate the adrenal cortex to release a hormone called aldosterone. And aldosterone will also cause increased salt reabsorption. It affects a different part of the kidney tubules, the filtering apparatus, but it still can add to the amount of salt that's kept in the body. Water follows salt, so you get an increase in blood volume, an increase in venous return, an increase in preload, which increases stroke volume, which increases cardiac output. And we're not even done with all of the effects of the amazing angiotensin 2. For job D, it stimulates the posterior pituitary gland. And the posterior pituitary gland will release a hormone called antidiuretic hormone. Posterior pituitary gland will release antidiuretic. That word means against diuresis or against urination. And it's also called vasopressin, which is very telling. It tells me that it's going to be a very powerful way to raise blood pressure. The way it does it is by causing the kidneys to retain more water. So it directly causes more water to be reabsorbed, whereas angiotensin 2 and aldosterone cause more salt to be reabsorbed, which then water follows. So it's a little bit less of a direct effect. Angiotensin 2 is the end result of a process that starts in the kidney. So the way we get angiotensin 2 is that the kidney can sense low blood volume and low blood oxygen, and it will release an enzyme called renin. And then renin starts a cascade of enzymatic reactions that end with the formation of angiotensin 2. Can write A2 like that. It's called the renin-angiotensin-aldosterone system, or RAS, and there are a couple of enzymes that are important in it. And so when someone has high blood pressure, those enzymes might be targeted. For example, angiotensin converting enzyme is the last enzyme to take angiotensin 1 to angiotensin 2. So ACE inhibitors, or angiotensin converting enzyme inhibitors, will then block the formation of angiotensin 2, which will theoretically lower blood pressure. I will explain the whole renin-angiotensin-aldosterone system in more depth when I do my videos on the urinary system. Pretty much everything I've talked about on here really emphasize how important it is for the body to be able to raise blood pressure when needed using these various hormones. But if the heart is under stress, it releases a couple of hormones that cause the kidney to lose salt and water. And these are called natriuretic peptides because the word natriuretic is like natriuresis, so it's got that Na in it to get rid of sodium. I'm just going to put this right here in yellow. So a heart has too high of blood pressure can release natriuretic peptides, and there's one that's called atrial natriuretic peptide, or ANP, and then another one that's called BNP. How do I spell this word? So there's ANP and BNP. BNP is measured in patients that have congestive heart failure, and it will go up if it's signaling that the heart is under pressure, under stress. Atrial natriuretic peptide also targets the kidney, but it's going to decrease salt reabsorption. And because it decreases the salt reabsorption, then blood volume will go down, which means that preload will go down, stroke volume will go down, cardiac output will go down, and blood pressure will go down. Test yourself. Hormones that affect blood pressure. Yeah, this is a pretty big page. I have 17 questions here, and this shows you how much meat was on that page of notes. You'll need to go through this list, I'm sure, many times before you really are good at it. Don't shortchange yourself. Your learning depends on your ability to return your focus to this hard content and help yourself to just practice over and over again. Keep at it. Keeping in mind that blood pressure is regulated by altering cardiac output and peripheral resistance, we'll look now at how your brain can have input into your blood pressure. Our brain knows what our blood pressure is at any given time, importantly because of baroreceptors. Baroreceptors can sense pressure changes. That word baro means pressure. And what they do is they fire action potentials up to the brain in response to blood pressure changes. What they actually do is send very quick action potentials when blood pressure is high, and then they're quieter. They send fewer action potentials when blood pressure is low. But they fire action potentials up to the brain. In response to blood pressure changes. Good places for these receptors to be on the alert for what's going on with your blood pressure will make sense, right? It makes sense that we can alert the brain best if we're close to the heart, right? To notify about blood pressure risk changes. And so they're also found, though, up in your neck on the carotid bodies, where the carotid artery splits to the internal and external carotid artery on both sides of your neck. And that is the other place where you're going to have these baroreceptors. And they can fire their action potentials up to the brain. So we could go like this. This would be like firing it up, and this is going to go up the vagus nerve to the medulla. And so we can put on here, this is cranial nerve number 10. And that's the vagus nerve. So these send their signal up to the brain. The carotid bodies, they send their signals up the 9th cranial nerve, the glossopharyngeal. They're already in the neck. They don't have as far to go. We also have chemoreceptors. And these will alert the brain to changes in levels of gases such as carbon dioxide and oxygen, or increases in the amount of hydrogen ions, which means that the blood is getting too acidic and you need to move that blood faster, right? So these are chemoreceptors. Chemo meaning chemical, and they fire their action potentials up to the brain. into the brain in response to changes in carbon dioxide, oxygen, or hydrogen ions. And those chemoreceptors are also found on the aortic bodies and on the carotid bodies. So, same places. Now, what happens when those signals reach the brain? The medulla oblongata is where we have our cardiovascular control centers. We have cardiac control neurons. And these are ones that are going to make the heart go faster or slower. And then there's also, in the same area, neurons that are dedicated to adjusting blood vessel constriction. So these are the vasomotor control neurons. Pretty cool, right? So the brain is going to get to have input both on heart rate, contractility, as well as vasoconstriction, and so it can brain. So the medulla oblongata is where we have our cardiovascular control centers. So we have cardiac control neurons. And these are ones that are going to make the heart go faster or slower. And then there's also, in the same area, neurons that are dedicated to adjusting blood vessel constriction. So these are the vasomotor control neurons. Pretty cool, right? So the brain is going to get to have input both on heart rate, contractility, as well as vasoconstriction. And so it can also pull all the levers to change blood pressure. Let's take two situations. Let's take situation number one, which is that the medulla, the cardiac control center, and the vasomotor control neurons have recognized that blood pressure is too low and needs to go up. Okay, let's raise it. So we'll use red for this. And what will happen then is that neurons in the medulla will fire down the spinal cord to somewhere in the thoracic region, or even lower if it's going to a blood vessel. But let's say that it's going to the heart. It will meet up with a neuron, and then these are the sympathetic neurons will be triggered. And then the last neuron in this track, this last neuron is called the postganglionic fiber in the sympathetic pathway. And it is going to bind to the heart and release norepinephrine. And you even know that it's going to release the norepinephrine onto beta 1 adrenergic receptors. And then that's going to increase heart rate and force of contractility. So I can put this over here to raise blood pressure. Sympathetic nerves will release norepinephrine to, number one, increase heart rate and force of contraction. I'll put contractility. That's how hard it's beating. Okay, and that's what is going to happen with this first example I gave you. But that's not all that's going to happen. The blood vessels will also be constricted. So other neurons will be able to go to arterioles. I know that's ugly looking. And then those will also bind to adrenergic receptors. And when this neurotransmitter, norepinephrine, binds here, It will either cause vasoconstriction of most arterioles. So we could actually label this right here. So these are arterioles. Most of these will constrict, and that will raise systemic blood pressure. Now, there are exceptions. There are going to be places where the blood needs to flow more, like arterioles in your heart muscle, in your lungs, or in your working skeletal muscles. Those, when the norepinephrine binds to certain adrenergic receptors on those, it can actually cause vasodilation. But on the whole, norepinephrine as a neurotransmitter will increase vasoconstriction enough that it will help to raise your blood pressure. And when veins constrict, we call it venoconstriction. Vasoconstriction of arterioles is having a direct effect on increasing total peripheral resistance, which will increase blood pressure. Okay, let me just erase this, the S on the end of that. And let's put a circle around here, okay? So this is what our sympathetic nerves can do to raise blood pressure after baroreceptors or chemoreceptors have sensed that things are off. Let's look at the alternate effect. What if blood pressure needs to be lowered? So to lower blood pressure, you can have parasympathetic nerves release acetylcholine in order to, we're going to decrease heart rate, we're going to decrease contractility. Both of those will decrease cardiac output. But what's interesting is that parasympathetic nerves don't usually go on to blood vessels. What happens there is that instead of it being parasympathetic nerves, we just get less sympathetic. So imagine if you're driving your car and you want to slow down. There are two ways you can slow down. You can, first of all, slow down by pushing on the brake. That's like what the parasympathetic is doing right here. The other way to slow down is just to take your foot off the gas. And if you take your foot off the gas, you're going to slow down over time. Inhibit sympathetic output. So there will be less norepinephrine going on to the heart during that time. The neural output for releasing the acetylcholine is going to go from the cardiac control neurons back down the vagus. So the vagus has two directions in it, and then it has lots of branch points, but don't worry about that for our purposes. And then it's going to release acetylcholine onto the heart, and it releases it onto receptors that are called muscarinic cholinergic receptors. But notice that it doesn't have a pathway to go to most of the blood vessels. So instead, what will happen is a general inhibition, and you'll have less norepinephrine released onto veins and arterioles. Test yourself. Neural control of blood pressure. Here you go. I've got 10 questions for you here. Pause the video, then go through these questions without looking at the notes. It's very important that you force yourself to answer these questions without looking at your notes. Then, of course, go back, check your answers, correct yourself, try again.